Hello and welcome. You are watching Lockdown TV. This is the pop-up news and discussion program from UnHerd.com. In recent weeks, we have been investigating the science around this coronavirus pandemic. We have had experts from across the world talking to us and sharing some quite divergent viewpoints. I'm delighted that today, joining us from Bonn in Germany, we have Professor Hendrik Streeck. Hello, Hendrik. Can you hear me?
Hi, nice to see you.
So you have just done a study which is being published this week, which focuses on this all-important question of infection fatality rate. Some of the experts we've spoken to previously have really differed on their estimates for what that is. We had Johan Giesecke from Sweden who thinks it might end up being as low as 0.1%. IFR, and we've also had Neil Ferguson who thinks it's closer to just under 1%, maybe 0.8 or 0.9%, at least for the UK. You've actually done a detailed study of a particular part of Germany. Tell us what you found.
So the important part to know is that we had a super spreading event in that small town of about 12,600 inhabitants. So there was a carnival celebration. Afterwards, we had like a massive outbreak of SARS-CoV-2, and that happened quite early during the epidemic. So there was a lockdown afterwards, and we had an increase of infection, and at the end, a decrease again because of the lockdown, and we had about 330, 340 infected individuals during that phase. That were the reported numbers. So we went in and did
is it a village or it's called Heidsberg?
Yeah, it's a county, County Heinsberg, and we went into Gangelt, which is like the smaller town areas, like a combination of several villages. And so we did a representative study there and invited households to come in. So these were this is a WHO protocol. And we basically followed that protocol of the WHO by inviting 600 households and to come every single member is showing up to our study center. So in total, we analyzed 405 households and 919 individuals. And what we found was that we had that 15%, not 3.1%, but 15% of the population of Gangelt was infected already. So that brings us to a case fatality rate with 7 deaths in that town or in this county, to a case fatality rate of 0.37% or 0.36%.
So that would sort of, as it were, on this spectrum, that would put you roughly in the middle between the various experts we've spoken to.
Well, we actually think we are a little bit high in our estimate because we did a very conservative approach. So, for example, and not to go too much into details, but from the 3% that were previously seen or reported to be positive, only 2% showed up in our study, which means that we have an underrepresentation of the individuals that were tested positive already. So if we are taking this into account, we are actually more in the range of 0.24, 0.26%. But we believe it's more important right now to have the most conservative estimate and rather be seeing the virus a little bit more dangerous that at the end it actually might be. But
so could I ask just some sort of beginners questions here? So for each of these 990 people, you're testing them for antibody presence, is that right?
So we tested them several folds. So we had a questionnaire, we had an antibody testing, and we did a pharyngeal swab. All antibodies we tested then so the individuals that had antibodies, we went back to our laboratory and put basically the antibodies together with the virus and looked whether there was neutralization. So it's a microneutralization assays. So in those individuals where we didn't find neutralization, we did a plug assay, which is another laboratory confirmation. And previously we tested the specificity of the antibody, and we found about 99% specificity. So that means there was only 1% false positive. And this is already corrected, and this is already taken into account in our study.
Are there other ways of being immune other than having the right antibody?
Well, there's a publication that suggests that T cells can provide a sort of immunity, and it is likely that they are providing partial immunity. We know this from other coronaviruses that if you had been infected with the coronavirus, that you might not see an antibody response, but the T cells can provide a second layer of basically a protection. It's not a full protection, it's not a sterilizing protection, but you are have a more asymptomatic infectious disease course.
And did you catch those T cells as well in your tests?
Well, we did not, but we are currently working on understanding the T cell immune response in those individuals.
So I guess the reason why everyone is so focused on this number of infection fatality rate is what people do is they say, well, if 15% of the population has had it, we will then see X number of deaths if it proceeds to pass through the rest of the population. Is that the right way to think? I mean, first of all, what sort of percentage do you think has had it in Germany? And if you have any of that number for the UK, that would also be fascinating. And how should we project it forward?
Well, the important part about the infection fatality rate is that that this is basically a measure of the virus, and it's not a measure of the town you got it from. So the 15% of immunity is really only about the town Gangelt, but the 0.37% you can use to narrow the model how many people might be infected. So for Germany, this means we have about 6,000 deaths. So if you assume that 6,000 people that died are the 0.37%, Germany has infected people of 1.8 million or even higher right now. So meaning that 2.2% of the population is probably infected already or had been infected with SARS-CoV-2.
But that would actually be quite a small number in terms of some of the ranges of estimates that have been floating around. I guess it makes a big difference in terms of what policy you pursue next.
But you can use this number already to calculate, for example, the number of infected people in the UK as well. Just knowing the number of deaths in the UK, you can back calculate how many must have been infected based on that number. But what you make out of this policy-wise, this is a question for the politicians.
So you think it's a safe or safe enough calculation to say that in the UK we've had roughly 30,000 deaths recorded, which is 5 times what you've had in Germany. So if that means you have roughly 2 million, we might have 10 million people who have been infected. Is that fair to calculate like that?
Yeah, it's a fair estimate to do, exactly. And I think the important part is also that we had a super spreading event. So what we are seeing is that we are seeing a much higher rate of infections after this event. And those people that had been infected at the super spreading event have also more severe symptoms. So we know from other respiratory infections, for example, influenza, and these are studies actually done in the UK, that volunteers were given viruses with different dose. So with increased dose of viruses, people became more sick. Now,
viral load is what they refer.
Yeah, it's a viral, but at the first infection, the viral load. So, and so you can assume, and we don't know this for certain, but you can assume that people that have been exposed to a high viral load might get more sick and have more symptoms.
Like doctor.
So, like the doctor, exactly. So now having the ability, now that's why we think we're actually overestimating the infection fatality rate to a higher level. And but for that, it's still a good starting point to see how low it actually, or like how many people actually might be infected.
So how do we project it forward? Let's say in the UK, if we've had 10 million people, if in theory everyone in the population was to become infected, we have roughly 60 or 70 million, so we could then see 5 times more deaths in the future. But as a virologist, what sort of percentage of the population might become infected? Do viruses ever infect everybody in a population, or what kind of estimates can we make?
Well, this is really hard to say because this has not really been studied for any of the coronavirus. If somebody might be actually immune against infection. So for other viruses, there are certain genetic traits, for example, that people are immune and can't even get infected. For SARS-CoV-2, we don't know this yet. Similarly, we can't really project how many people might actually need to be infected to have a level of immunity, as we don't even know if this virus brings sterilizing immunity. We know this from other coronaviruses, that there's a partial protection, but we don't know it for SARS-CoV-2. And what is interesting is that in our study that 22% with actually high antibody titers, partially high antibody titers, had no symptoms at all. So we had like 1/5 of the population that was infected had no symptoms, but had been exposed to SARS-CoV-2.
So Neil Ferguson, when he was talking to us, maintains that he thinks that number is nearer 0.8 or 0.9, at least for the UK. He made a big point that the number could be different for different populations depending on their demographic layout. So he said that in New York City it might be as low as 0.6 because it's a young population, but in the UK as a whole it's more likely to be 0.8 or 0.9. But you would say that the UK, in your estimate, is nearer to between 0.2 and 0.37.
Well, Neil Ferguson is right with this. It depends on the demographics. And if you have a younger population, it will be probably lower, the infection fatality rate. But comparing this to the UK, I think we have a very similar demographics.
So how should we, as it were, outside the scientific community, what should we make of the fact that Professor Neil Ferguson thinks it's 0.9% and you think it's between 0.2 and 0.3? How do we explain that difference?
Well, it is a question what data Neil Ferguson is using to come to the estimate of 0.6, 0.9%. If it's, to my knowledge, there has not been a study this way. There are several studies being conducted right now in this similar fashion, but there has been not the results of any study like this to that really tried to find representative measure to understand the infection fatality rate. And but we can all only contribute to the knowledge. And if he has other studies that is showing like a much higher infection fatality rate, it might differ.
That group, the Center for Evidence-Based Medicine, they believe the IFR is even lower, I think, than what you're saying. That they're looking at previous epidemics and how the initial estimates always seem to come down for various reasons as more information becomes available. So they think that the infection fatality rate could be as low as between 0.1 and 0.3 is what their current estimate is. Would you comment on that?
Well, they're probably right. I already said before that there are several factors in our study that make us believe that we are overestimating the infection fatality rate. But, and we are discussing this in the publication, why we actually think that it might be lower. But the true infection fatality rate, we can only infer really after the pandemic. It's very hard to measure this during this pandemic, and there's already data emerging that actually says it's lower than 0.37. We were very surprised in our study that we find only a 15% risk of getting infected in your own household if a person is infected. So this is similar data that was actually already described in Iceland or in Singapore, but the secondary attack rate is actually quite low, and it's similar to that of influenza or like MERS or SARS, where it has been described as well. So,
where if you don't get it at home, where do you get it? What are the activities we should be avoiding if we don't want to catch it?
Well, it is surprising that we don't see a clustering in the family. So for norovirus or rotavirus, right, those that are actually transmitted by smear infection, you often see that the whole household is having diarrhea, but you're not seeing that whole households are actually getting SARS-CoV-2. And there's a flat line for us, or if it's a 1-person, 2-person, or 3 or 4-person household, there's the same rate of infection in the households. What the most important question is not how to avoid to get infected, but what is actually the events where you get those big outbreaks and where most people are getting infected.
What was that? What was that carnival? Was it outside? Was it inside? What were the characteristics of it?
So Ischgl, where we had the other super spreading event, and the carnival celebration, Kappensitzung, had some very similar features. So there were people dancing, celebrating very close to each other. They were singing, there was loud speech. And what probably gave the transmission at the carnival, where we are not certain about, is that people were kissing each other on the mouth. So that's very traditional there during Carnival, and that way the virus was just spread to the different people. We are assuming that even almost 40% of the people at the Carnival became infected that attended the Carnival celebration. And in Ischgl, we assume that the bartender who was infected was going with a whistle through the crowds and just blowing the viruses in the air. And but it was always bad air, lack of circulation, closed celebration.
Were they outside or inside?
Inside. Both times they were inside. Yeah. If something is outside and people can keep a little bit distance, it's not likely that it's going to be a super spreading event. Individuals might get infected, but it won't be like this big burst of infection. We had another super spreading event in Germany, which was in a bar, a club, where they were dancing extremely close and singing to the music. And again, it was basically the time and distance from one person to the other that caused this outbreak.
This sounds like very bad news for nightclubs.
Yeah, I guess.
We had another question that is talked about a lot is children. You mentioned that you've discovered some things about virus transmission amongst children. I know that in Switzerland, they've now decided that there are no examples of a child infecting an adult, and so they're going to bring junior schools back. What's your evidence on the question of how infectious children should be and what that means for schools?
There had been a publication of the suggestion that the school is the transmitter of the virus. And after the super spreading event, the schools remained open. But most infection actually happened at the super spreading event and did not happen afterwards to that extent. So if the school would have been the big transmitter, we would have seen much more, we would have seen many more infected children, and we would have seen basically a different center of infection, which was not the super spreading event. So we can at least say that the school was not the reason for the outburst in that city, because we have very few infected children in the cohort.
Right. So let's just talk for a moment about Germany and the UK. We talk about Germany a lot. It's held up as the kind of gold standard of how people should have responded to this. And yet, if you're saying the infection fatality rate is the same, or we should presume it's the same in the UK, that would suggest that there is nothing particularly different about treatment or anything in Germany. You know, if the same percentage of people die if they become infected, is it just that more people have been infected in the UK than Germany, and that's the difference between the statistics?
I don't think it's the lack of optimal treatment, but rather that the UK may have more infections.
So Germany is currently tentatively coming out of lockdown and trying to see what effect that has on the R rate. Is that the correct policy for them? Is that the right way to manage the disease going forward?
Well, it's very hard to comment on politics, and something that I'm trying to always assume. My only recommendation is for all the policies worldwide is that we know that that we can only see the effect of a measure if it's a more stricter measure like lockdown or like loosen some of the measures. You need to give it time that we actually see it. So it needs 2 weeks, 3 weeks that we are seeing the effect. And that was something that we missed at the very beginning. We went very quickly into a lockdown, but we should have taken us a little bit more time and see, well, does it already help to cancel like big events where people are closely dancing? Does it help to really enforce hygiene measures? Or do we really have to shut down the stores and shops? Now we can't see which effect was actually the best in the lockdown. And now I'm hoping that we are taking enough time getting out of this that we can actually nail down what would be the best way forward and what we need to keep up to achieve like a control of the viral replication.
Is it possible, do you think, sort of practically and scientifically, to maintain a suppression of a new virus like this, so that it doesn't grow significantly in the population until the point of a vaccine? Is that a feasible policy, do you think?
No, I don't think this is feasible for two reasons. The first problem is we can't seriously say if we're going to have a vaccine. I mean, me coming out of HIV vaccine research or hepatitis C vaccine research, we are still waiting for a vaccine, and it's a decade of research. And there has not been a successful vaccine against any coronavirus. So now saying in 18 months we're going to have a vaccine, it might be that we have a vaccine that can be tested, but to show that it is efficacious and that it really protects from infection, we cannot say that. Mm-hmm. The second part is that we do not know how the immunity in the population is actually playing out, if this is going to have an effect on the control. So it might, but we know also that we can't stay in this situation right now.
What does that mean, how immunity plays out? What do you mean by that?
Well, we don't know if we're going to have a partial sterilizing immunity, if we have full immunity against the virus, or no immunity at all. I assume it's going to be the same as any other coronavirus, HKU1, OC43, etc., that we will have a partial protection. So it's going to be a protection for a year, 2 years, and when you get sick again, you're not going to get as severely sick as before. Right. And this will have a big effect. And this is more what I'm hoping to see, what we're going to achieve. And it's a much more viable way forward to allow a partial protection than to really hope for a vaccine. That might take just years.
So how would you allow a partial infection that doesn't become the whole population? You know, what does that mean?
We need studies on understanding whether hygiene measures reduces the infectious disease or infectious viral load dose so much that a person gets infected but is remaining asymptomatic or has only very little symptoms. So if it's true that only the viral load dose determines, or like one of the main reasons, the viral load dose is determining the symptoms and the severity of the symptoms, we have something on our hands where we can achieve a partial protection in the population that would allow us to have a normality, but at the same time control the virus.
That would mean advising people to wear face masks, avoiding going to nightclubs, that kind of thing, or a long-term regime of less potential spread.
Well, I don't know if it needs to be a long-term regime, but we need to closely monitor now in a population with strict hygiene measures. I'm not even talking about face masks, but it's like partial social distancing of like 1 meter, 2 meters, repeated like hand washing and like hand disinfectant use, the sneezing and coughing etiquette, and similar measures. And we will need to see repeatedly over the next weeks and months to see if this has an effect on the transmission and the transmission of the viral load dose, because that would help us to understand whether the virus can be controlled just by hygiene and not by any other measures.
So actually, so the goal in that scenario would actually be to get as many people infected as possible with a small as possible dose, as it were. Is that?
It's not a suggestion, it's a hypothesis. And I think it's important to state that I'm not suggesting that you have to infect people now at a low dose. But it is something that we know from other viruses that this is the case, and there's no reason that it wouldn't be the case for SARS-CoV-2. And we are seeing evidence that this is already happening. So this combination would allow us to have people getting infected without having severe symptoms. And that would help in the control of the virus. But it's a hypothesis that needs to be tested.
How do viruses die? Or, why was it that SARS or previous viruses that have happened, how do epidemics progress in the normal natural world? How do they end?
Well, with SARS, we had luck because SARS is replicating deep in the lungs, but SARS-2 is replicating in the throat. So SARS-2 is more easy to transmit, but it's not as severe as SARS-1. Now, with the high or low infectability or contagiosity of SARS-1, we were actually able to eradicate the virus by curing the individuals that had been infected. So it was not easily transmittable, and therefore we could get it out of the human system. I'm convinced that we are not going to get rid of SARS-CoV-2. So it's going to become an endemic virus, which means it's going to live in our population, and we have to start living with it and find measures that people are not dying of it, but at the same time we can achieve a normality.
And so that's not herd immunity then? This phrase has become very charged in our conversation because people doesn't sound very good or people are worried about it. Is herd immunity the only way to end this pandemic?
Well, we cannot end it because we have every year other endemic coronaviruses that are bugging us. So, for example, in the fall, we actually had in Germany HKU1 very often tested in our laboratory. It's a coronavirus that causes very similar symptoms, but people are just starting to live with this and are starting to have partial immunity. They get a little bit sick, have like flu-like symptoms for a week or so, but then it's over. And this is something what I'm assuming is going to happen to SARS-2 as well, that we have a infection level sometimes going on like a little wave, but it's not really dramatic anymore. And it's more like a partial protection, but not really like a herd immunity that's going to happen.
So it sounds like then that we can't control it entirely, in your opinion anyway. We're not going to be master of this virus and keep it entirely in a box or eradicate it completely.
We will not be able to eradicate it without a vaccine. And so until then, we have to start to live with this.
Professor, thank you so much for your time. That was fascinating. Thanks for sharing your results with us.
Thank you.
You have been watching Lockdown TV from UnHerd.com. That was Professor Hendrik Streeck of the University of Bonn, who has done one of the most thorough investigations into immunity and the prevalence of the virus within a population in Germany. And he believes that it is between 0.2 to 0.37% is the true infectious fatality rate. That should have meaningful consequences for policymakers. Thanks to him, and we will be back in a few days' time.